Hi, everyone. So welcome back. And I know that there was a lot to cover yesterday in regards to the use of the different antiretroviral therapies. And if there are questions or concerns about that, definitely feel free to let me know. I will put together a cheat sheet, like I said, but I also plan on putting together some example cases that I will give to you. And then over the next couple of days, after you've had a chance to look at them, I'll put together the answers and we can talk through some of those. So if there are questions, I hope that we can kind of work together to make them a little bit more understandable. And today we're going to be talking about what happens if people don't take their antiretrovirals, and we're going to be dealing with the opportunistic infections that might result. Now, our objectives for today are to understand the symptoms of 5 common opportunistic infections, but also the risk factors that would predispose people with HIV or with AIDS to developing these conditions. We want to create optimal treatment regimens for these conditions based on guidelines, but also on patient-specific factors, things like allergies, other medications that they're taking, how they've responded to antibiotics before. We want to understand the difference between primary and secondary prophylaxis and how to use those terms in regards to our members or our patients and how to prevent these conditions. We will create optimal prevention regimens for these conditions, and then we will be able to counsel patients and their caregivers on the use of medications used in both treatment and prevention of the 5 opportunistic infections that we'll talk about. So what is an opportunistic infection? So we know that the world is full of all sorts of bad bugs, and they cross the board from bacteria and fungi and viruses, those things that we talk a lot about and things that you'll learn a lot about over the rest of the semester. But we're also talking about helminths and protozoa and occasionally even prions. So opportunistic infections typically don't happen in people who do have a competent immune system, and unfortunately, the infections are going to be much more severe or even more frequent because of immune suppression. These opportunistic infections were once a major source of morbidity and mortality prior to the advent of antiretroviral therapy, and they still can cause illnesses in people who don't take their medications. Or worse, and from a public health perspective, kind of more concerning is for those that don't know that they have HIV. And we did talk a little bit about how to make sure that people who are living with HIV do know their status last year when we talked in pathophysiology. But we also know that HIV is not the only thing that can lower immune system response. So people who are on immune suppressant drugs, who are using them to prevent organ rejection, people who are using chemotherapy to try and treat cancers, but oftentimes there's even an idiopathic CD4 lymphocytopenia, and these are not the only things that could potentially lower somebody's immune response. If you think about even people with no other conditions, comorbid conditions, things like chronic fatigue, malnutrition, stress, even pregnancy and aging can all lower the immune response. And while they can cause some infections in otherwise healthy people, they don't usually cause opportunistic infections on their own. So a couple of important considerations before we start talking about the medications themselves or the diseases themselves. We want to consider what the difference is between primary and secondary prevention. So primary prevention is a person who's never had symptoms of the illness, and we are trying to make sure that they never do have symptoms of those infections or illnesses. Whereas secondary prevention is when a person has had symptoms of the illness, and we're trying to keep them from having those symptoms again. So I know you've talked about primary and secondary prophylaxis with some cardiovascular conditions in the past, and kind of think about it the same way. This distinction is going to play a role in how we manage some of the infections we talk about today. And another thing to keep in mind is that when it comes to treating or preventing opportunistic infections, one of the most important things is that we get them on an effective antiretroviral regimen, that they can be adherent to that regimen, and the hope is that that will inhibit viral replication enough that you can get a robust immune response and your CD4 count starts to go up and you're able to fight these infections off again. Some of them can be prevented by immunizations, and I know you've talked in the past about streptococcal pneumonia, and you know about the ability to immunize against hepatitis B, even if you haven't talked too much about the condition itself. And so our discussion today is going to focus on antimicrobial therapy and how to avoid some potential exposures if that's possible. And you'll notice in some of the upcoming slides that that's not going to be possible in all cases. So this is just a picture of some of the opportunistic infections that do exist out there. And like I said before, we are talking not only about funguses, bacterial, and viruses, but also about protozoa, helminths. And what this slide brings up that I hadn't mentioned before is that there are even some types of cancer that are considered opportunistic, some of which are caused by viruses and some which might potentially not be. And I know the picture on the top left should be familiar to you. If you're looking at this graph, the blue line is a person's CD4 cell count when they are infected with HIV from their primary infection right down through until they die. But also we have the red line, which is the viral load. So as we've kind of talked before, the CD4 count and viral load could actually be seen as kind of a tipping scale, whereas one goes up, the other one goes down. And to prevent the CD4 count from going down, you get on medications that will keep the viral load as low as possible, which then keeps the CD4 count up. You'll notice at about 200 cells, we start to see opportunistic infections. And the table that's listed here gives a couple of examples of when we're more likely to see certain types of infections based on a person's CD4 count. And we'll talk today about a number of them, but 200, 150 are some pretty important numbers that you should know in regards to the conditions that we're talking about today. So first, we're going to talk about some fungal opportunistic infections. And as I said, there's a huge number of them that are out there and could potentially have serious consequences in somebody who does not have an immune system. Our focus today is going to be on two of those. One of them, candidiasis, which everybody has probably heard of in regards to the fact that women could have vaginal candidiasis, or people who are using steroid inhalers can also have oral candidiasis. We're going to talk a little bit more about that in the setting of somebody with AIDS. We'll also talk about an interesting fungus known as Pneumocystis jirovecii, which was previously called Pneumocystis carinii, and that kind of plays a role in how we're naming this condition. But the rest of them are important, and for people who wind up working in infectious disease or in HIV therapy, these will be important ones to know in the future. So candidiasis is usually caused by Candida albicans, but a number of other types can cause infection as well. Unfortunately, for people who are severely immune compromised, the ones that are listed here, Cleparata, Crucei, Tropicalis, etc., are more likely in people who are severely immune compromised, but they're also potentially resistant to a number of the medications that we would use to treat Candida as first line, which could increase side effects and increase drug interactions. So we'll talk a little bit about that, but do know that generally speaking, especially in people who are immune compromised with HIV, at about 200 CD4 cells is going to be albicans as first line. These can involve mucous membranes, but they can be systemic as well. So as the immune system fails and the severity of that immune compromise gets worse, you'll see that these can actually become systemic very quickly. Not all Candida infections are opportunistic, and I raised the question, are they? Because I want you to think about a couple of things. We talk a lot about thrush that's caused by inhaled corticosteroids, but inhaled corticosteroids, the purpose of taking steroids is to suppress the immune system. We also see oropharyngeal candidiasis in people who are wearing dentures, in people who are using antibiotics, and in women who are dealing with stress or hormonal changes after puberty. So a number of those things can actually lead to a decrease in your immune response. Generally, they are relatively temporary, but it's important to consider that these are actually immune suppressants. And then when it comes to vaginal candidiasis, a number of things that are also considered immune suppressants could play a role, including pregnancy, uncontrolled diabetes, stress, and the use of antibiotics. The two that we're going to talk mostly about are oropharyngeal candidiasis and esophageal candidiasis. The only difference is where in the GI system they are systemic or symptomatic. And what I want you to understand is that oropharyngeal candidiasis and vaginal candidiasis are not AIDS-defining conditions. Obviously, people without HIV/AIDS can have those conditions, but esophageal candidiasis, when that happens, we should absolutely be considering at least getting an HIV test, because this would be considered AIDS-defining. And as an example that I always give, we had a patient a couple of years ago when I was at ECMC who had come into a number of emergency rooms in the area over the year prior to showing up at ECMC, complaining of issues related to what she thought was GERD. And a number of the doctors thought the same thing. She was having retrosternal pain. She was having difficulty swallowing. It hurt to eat. So the doctors put her on a proton pump inhibitor and sent her home. A couple of months later, she had taken the medications. The medications had run out. She was still having issues, still having complaints. She was starting to lose weight, so she went back to the doctors, and instead of doing anything, the providers that she worked with put her on an H2 antagonist and another course of the proton pump inhibitor. This happened again, and a couple of months later, she was back, and she wound up being put on, a long course of proton pump inhibitor. And again, a couple of months later, she came back, and as this complaint was going on, they finally decided after about 9 months to do an esophageal scope, an endoscopy. When they did the endoscopy, they actually did find that she had Candida throughout her esophagus, but instead of considering that this was an HIV diagnosis, they gave her the antifungals and they sent her home without even talking about the fact that this might be something bigger than just candidiasis. And when she finally came to ECMC, it was because she had tried the other places and nobody could seem to find an answer. They did the scope, they figured out that this was again esophageal candidiasis, and they finally did test her for HIV, and she was positive, which we should have expected right from the beginning, but the testing was never taken care of appropriately. So it was about a year after she started showing signs and symptoms of esophageal candidiasis that she finally got her diagnosis of HIV. And so that's a year that we could have been treating her HIV, which could have potentially stopped a number of the problems she had had over that previous year. So these are a couple of pictures of what oropharyngeal candidiasis looks like. And again, I'm pretty sure you've seen these pictures before when you talked about the inhaled corticosteroids. The types that we're going to talk about, this is the pseudomembranous form, which is those white plaques on the buccal mucosa, on the tongue, or on the palate or oropharynx. They can lead to a cottony feeling in the mouth. They can lead to a loss of taste, and sometimes, rarely, they can cause pain during eating and swallowing. One of the other considerations is that if it does cause hoarseness, there's a sign of laryngeal involvement, and that doesn't necessarily change the treatment, but it is important to note in terms of how far this has progressed. Those white plaques are actually really easily scraped from the mucous membranes. You could take a tongue depressor and actually rub it across the tongue and remove all of those without any pain. Oropharyngeal candidiasis or candidiasis can actually cause angular cheilitis, which is painful fissuring in the corners of the mouth. And generally this is bilateral. The corners of your mouth are going to be very red, and there's going to be fissures in those areas. On diagnosis, there is usually a clinical suspicion. You're going to be able to say, hey, this looks like candidiasis. So you don't necessarily need to do any sort of special diagnostic workup. But if there is confusion or any sort of question, generally you can do a stain or even a potassium hydroxide prep. Culture isn't really needed unless this is recalcitrant or recurrent. So if it is something that keeps coming up, even though you're treating with the medications we'll talk about, when it does happen that those medications don't seem to be working, then you would do a culture, and you could also do sensitivities to find out what drugs might potentially work better for the treatment of this drug or condition. And then we have esophageal candidiasis, and in this case, there may not be any sort of white plaques in the mouth, but patients will complain of difficulty swallowing and that retrosternal pain that I talked about with the patient that we were working with. It can occur with oropharyngeal candidiasis, but it doesn't necessarily have to. And the only way you can diagnose this is with an endoscopy. And what you will see, as these pictures show, are those white mucosal plaques inside the esophagus. The top picture is a little bit less severe than the picture on the bottom, but you can see that it can have some pretty severe lesions shown. If you do have a diagnosis based on the endoscopy, you can do a biopsy, or what many people will do is they'll treat presumptively based on symptoms because that's less invasive, and patients tend to be better equipped to handle the treatment rather than the biopsy. If for some reason treatment didn't work, we would again consider that there might be some alternative organism causing the symptoms. And not only are we talking about different species of Candida, but we would be talking about different viruses as well, including herpes simplex or cytomegalovirus. And again, other things can cause this. So the symptoms of esophageal candidiasis do very much look like GERD. So when the endoscopy is clear and the patients are complaining of this, absolutely think about GERD. But if it's constantly being diagnosed as GERD and medications aren't working and you just keep throwing PPIs on the person, at some point you've got to start thinking about what the other alternatives could be. And that's when the endoscopy is very helpful. So how do you treat it? When you're dealing with oropharyngeal candidiasis in HIV-positive people, the mainstay of therapy is going to be azole therapy, especially in people who have CD4 counts less than 100. The treatment of choice is fluconazole, 200 milligrams times 1, and then 100 milligrams for 7 to 14 days. And this is actually more efficacious than the topical clotrimazole that we'll talk about in just a second. And again, if for some reason fluconazole doesn't work, there is the ability to use other azoles, including itraconazole, posaconazole, and voriconazole. But you have to consider that these medications are not first line because each of them does exhibit a unique spectrum of activity and increases side effects and drug interactions. Additionally, you have to consider cost. So there are topical agents as well, particularly in pregnant women. These are going to be used, and options include the clotrimazole troches. One of the concerns you'll notice here is that this is 5 times a day. There's also miconazole buccal tablets, which you would put right over the in that dent above your incisor, and once a day you stick that in there, and that is enough for that one. But again, you use it for 7 to 14 days. And then less effective, but something that we still do see quite commonly, is nystatin suspension, and that's going to be a swish and spit 4 times a day. This is less efficacious than the topical agents we talked about, and definitely is less efficacious than the systemic azoles. And then another question that will come up is, do you use both of them together? There's no reason to use both of them together, although many prescribers will do this. I think sometimes they think that the topical makes the patient feel better, but if you're using one, there's no reason to use both of those together. For esophageal candidiasis, the treatment of choice is fluconazole, 400 milligrams a day times 1, and then 200 to 400 milligrams for 14 to 21 days. So the difference between oropharyngeal and esophageal is the time. For oropharyngeal, it's 7 to 14. For esophageal, it's 14 to 21. And you can imagine that's pretty subjective. Other azoles can be used in the instances of resistance or recurrence, and in this case, because this is not in the mouth, there is no need or no indication for topical therapies. Echinocandins and amphotericin B can be given as alternatives, but they are all given IV and are pretty expensive, and they do have their own side effects, so they're usually used only when all else fails. The one time that might not be the case is during pregnancy. The azoles are teratogenic, so for the oropharyngeal, you can use the topicals, but for esophageal, you'd have to switch to amphotericin B. Azole side effects include hepatotoxicity, GI upset, and rash. And one of the interesting things about voriconazole is that it can cause some visual disturbances at high doses, and the incidence of those visual disturbances and the incidence of rash tends to be pretty high with voriconazole compared to the other ones that we will talk about. So as examples of things that might be important for you to know about the different antifungals, fluconazole does occur in both a tablet and an IV formulation, but because the drug is hydrophilic, bioavailability is equal for both. So you can give a tablet if the person can swallow, and you'll get the same amount of drug in your body as you would the IV formulation, and it's going to be cheaper to give the tablets than it would the IV formulations. So if you've got the option and the person is able to swallow, the PO formulation is a better choice. Also with this drug, food and gastric pH don't affect the absorption, and this gives the ability for once daily dosing, and it is less likely to cause drug interactions than the other ones we'll talk about. And one of the interesting things about this is that you will see inhibition of 2C19 and 2C9 at a much greater rate than you do 3A4. And it's only with much higher doses that you see the inhibition of 3A4 become clinically significant. Itraconazole, we talked about when we talked about the tinea capitis and the onychomycosis. There is a tablet formulation, a capsule formulation, and an oral solution, and there is a huge amount of bioavailability between these, so you can't use them interchangeably. Regardless of the formulation, for the most part, bioavailability tends to be pretty low. So the capsules do require food, and they should be given with an acidic gastric pH. So we talked about cola, cranberry juice as things that might potentially increase the availability of the drug, and things that might decrease the availability would be things like proton pump inhibitors or H2 antagonists. So in a case where somebody is mistakenly diagnosed as having GERD, make sure you get those patients off of those drugs before you start the antifungal drug. Solution isn't necessarily altered by gastric pH, but it does cause much more GI upset than the other formulations. And dosing of this is usually 200 milligrams a day or 200 milligrams twice a day for up to 28 days. Something to consider, though, is that a lot of people will try to do 400 milligrams once a day to make it easier for the patients to take. It does not happen to help with absorption. So 200 milligrams BID tends to be the better choice. And we also don't recommend capsules being used just because they are so variable in their bioavailability, even though they might be easier to take than the solution. These drugs do cause CYP3A4 inhibition and P-glycoprotein inhibition as well. And the other choices are posaconazole, which comes as an oral suspension and delayed release tablets, and voriconazole. When it comes to posaconazole, the oral suspension should be taken with a high-fat meal to enhance absorption. And food is also recommended for the delayed release tablets, though there is less variability than with the suspension. So if they're recommended and a full meal can't be ensured, we do need to consider the different options that are available. And the dosing for this is usually only for resistant organisms and is 400 milligrams BID for 3 days, and then once daily for up to 28 days. And then voriconazole, which comes as an IV, a tablet, and a powder for suspension, has a high bioavailability, but that bioavailability is reduced quite a bit if taken with a high-fat meal, so it should be taken on an empty stomach. The IV formulation, because of the vehicle that it comes in, can only be used in people who have a high creatinine clearance. It has been used in lower creatinine clearance with severe infections where the risk is less than the benefit. And so we do need to consider that, it's off-label when that is the case. and oral can be used without regard to renal function. So it's only the vehicle itself of the IV formulation that causes the problem with creatinine clearance. And dosing again is 200 milligrams BID for up to 28 days, and this is typically only used for resistant organisms. There are a number of drug interactions with this one because this is a big inhibitor of CYP3A and even 2C19. We do have to consider the genetic variability of 2C19 when it comes to how much that is impacted. But what I will say is that with voriconazole, there are a number of drug interactions with those HIV medications we talked about yesterday. So it is important to consider how we use it and if dose adjustments are necessary. And how do we prevent candidiasis? We keep the CD4 count up, and most specialists aren't going to recommend either primary or secondary prophylaxis. So once it's treated, most people will say, we're good until the next time it happens. The reason for this is that the effectiveness of treatment is very, very high. There's low mortality associated with acute disease, either oral or esophageal. The costs tend to be pretty expensive even when they are generics, and there is the risk of resistance if we're using them long term. And there's also that risk of drug interactions that we talked about. The only time that secondary prophylaxis might be considered is if there is concern about invasive disease and if there are several repeated cases of infection in a person who's got continued low CD4 count. Otherwise, we're not going to do it.